Hello, everyone. Welcome to our very first live stream with panel members. So this is something new that we're going to be trying on this channel where we're going to have other people joining me. Most of them, all of them here today are nurses, here from the healthcare space, but we're going to have all sorts of people in the coming days from all over, which I'm super duper excited about. So today we're going to be talking about the Kira Johnson case. This is having to do, just in case you want to kind of know going forward, so if it's something you don't want to watch, about giving birth and when things do not go well when you're giving birth. We're going to be talking a lot about how people in the BIPOC community, particularly Black people, experience a much, much higher rate of dying within the giving birth, pregnant, all of that phrase. And Kira was one of those people that did not survive that experience. We're going to be going through her experience, looking at it's, I think, like a very tragically common, not common, but like her case is something that I have seen in my own practice play out. So I wanted to bring some attention to it. It is an active court case that is going on. So we'll be talking through it. We'll be getting some excellent insight from my lovely people who have joined me here today. And yeah, we'll be going through it. I'm going to do a brief where we kind of are with this case, kind of background story. And then we'll hop into some introductions with everybody that is here. And we'll just kind of talk about it. So if you have ask questions for them, if you have questions throughout the whole thing, if you have opinions, as always, more than would love for you to share them. And one of our nurses here today, Chelsea, is actually a labor and delivery. She is we called her our guest of honor, because this is what she does. So let's dive in really quick and just kind of review what the situation was and what happened. And let me know in the chat if you guys have heard of this case. This actually happened in 2016. This is Kira Johnson. We can bring her back up. She was 39 years old, lived in Los Angeles, and she went in for a C-section this was her second C-section. This was her second birth. She had a toddler at the time as well. And she had been married to Charles for 10 years. She was, a general cool human. I think one thing I want to highlight is just that these are people. They're not just like, a name in a news story. So she could speak 5 languages. She raced cars. She had a pilot's license. She was a skydiver. And at this point in her life, she was now a stay-at-home mom to their toddler. She went in, she had a C-section. The C-section was very, very quick, even though it wasn't an emergent C-section. And that's something that's going to come back kind of in the story later. After she had her C-section, while she was in the PACU, she started to complain about a lot of pain in her abdomen. A bunch of blood started to come out in her Foley, which is what goes up into your bladder and should be draining urine. And it started to drain a bunch of blood. These are, she started to show more and more signs of like pain. Her heart rate is going up. And they ordered a CT, which is an imaging study of your abdomen. And it never got around to being done. Essentially, they ordered it stat. It didn't get done. She continued to feel worse and worse. Eventually, they finally took her back to the OR and found 4.5 liters of blood in her abdomen, which is almost as much blood as you actually have in your body. They attempted to be able to, what they realized was they had nicked her bladder in a very, very fast C-section. So the C-section took 17 minutes, which is a lot shorter than C-sections usually do. And they nicked her bladder. She basically bled out into her abdomen. No one listened to her when she said, hey, this is happening, like I'm in pain. Her husband reported that they kind of said, when she was saying something is not right here, that they were like, hey, you're not really a priority right now. Got to the point by the time she got to the OR, they weren't able to do anything. And she passed away that night in the OR. That's kind of the horrifying road that sort of leads us here, right? And this is something that we know that happens a good, like 3 to 4 times more often. You will see Black people die in labor, delivery, that whole perinatal period. This is something that I have seen my own patients just tell me horror stories of, we delivered in the, like, of me even comparing my experience. Like, I delivered in that hospital that my patients will tell me, hey, this is where I gave birth. This was my experience. I'm like, well, I delivered in that hospital and I was not, like, I can without a doubt tell you, like, I was not treated the same. There is so much at play here. We need to listen to our patients. And they've done a bunch of studies, and really the big thing they can come up with is, hey, even if you factor out everything else for like, age, if you factor out comorbidities, other medical things going on, how much money people make, where you live, the big difference will still come down to race a lot of the times, which is just showing an underlying racism that obviously Kira experienced, that I have seen countless patients experience. And so we're going to talk about it today, essentially. So that's kind of our road that got us here. We're going to go through the actual lawsuit because I think it's good to go back to the primary source. We have a beautiful panel here of healthcare people who are going to just weigh in on whatever their thoughts are, any comments that they want to have. Maybe they're like, if they've had experiences, anything relating to this, and just kind of share. That's the beauty of, hopefully, I think, collaborating with everyone, answering your questions that you have, and all of the things. And everyone on this panel, I do want to come out and say, if they have social media or anything they would like to promote, it's going to be in the description of the video. So please, please, please go and check them out, because they don't really get anything by being here other than being here and getting this. So please go check out their stuff. They are awesome humans. And I'm very excited that they're here. So does everyone want to just say hello really briefly? Any initial thoughts, any comments, other than this is horrifying?
Has anyone started talking? Can you hear me?
Yes.
Okay, well, with this one, I had, what is it called? Placenta accreta or something, where your placenta is attached to your organs. I was high risk. I was told multiple times, not a big deal. You've had 2 C-sections before, quit being dramatic. Everything's going to be fine. I saw this doctor from like when I found out I was pregnant till the week before I delivered. And he was not worried about it at all. It wasn't a big deal. He told me I was being dramatic. You care, quit overthinking it. It's going to be fine. I was like, okay. Now I've been critical care. I've been in critical care for 10 years.
As a nurse practitioner and a nurse.
I said, this
for everyone
is okay.
Out there.
He knows what he's doing. Even though I knew better, he talked me into this relax. So we go to the C-section. I bleed over 2 liters. I have to get a hysterectomy. He's in the NICU for 5 days. And I'm just like, why did I not listen to myself? Why did I ignore the signs that things were not going well? And my husband's like, well, this is what you said was going to happen. I was like, I know, but he made it seem like I was being so dramatic. So then I felt weird about even bringing it up again. So yes, I've had that experience where you know what you know, but still someone talks you into thinking you're being dramatic. And I'm so sad to hear that she did not make it.
I know. I am so sorry that you had to deal with that.
At least that's my husband's like, I guess my husband was telling them like, I need you to save her. If the baby dies, I don't care about the baby. I was like, don't say that. It's like, you cannot die. I don't know how to take care of these boys. So I'm like, okay.
Yeah.
I guess I love you too. But
and that's like horrifying that's the bar. You know what I mean, Nicole? Where it's like, oh, well, at least I survived. That was that something that you were worried about going into labor? Because I can tell you, like, I was not worried, like, am I going to die? I was worried about what organs might I have a new hole in? Like
before, but I wasn't worried. Well, I was always worried because, the tattoos, the dreadlocks, people get some kind of way when they see me initially. So I'm never really people's first priority, honestly. But as far as dying, no, I didn't think I was going to die. But my husband's like, he pulled out this, he called it a pineapple, and it was bleeding everywhere. And he was like, he was just telling me to turn around and to leave the room. And I got scared. I was like, okay.
Oh my God.
So he's still traumatized. But luckily I survived. Our kids are fine. But yeah, I didn't know I was that close to dying until I woke up and they were like, oh yeah, things went a little bad. We had to do the hysterectomy. And I was like, no, you told me that wasn't needed. It was like, it was going to be an emergency thing. And they're like, when we got in, we just couldn't help you. And then my bladder got nicked. So I had to have a cystoscopy and a Foley and get bladder surgery. It went kind of off the rails way fast. And I was not prepared for that. And, I'm 40. So you mourn not being able to have kids anymore.
Yeah.
But yeah, but like in her story, it all happened fast. And my husband was like, they were telling me everything was fine, but it wasn't fine. But I've been in that situation too, where you're just saying things to just calm everybody down. You don't consider it a lie, but you know it's kind of like a lie. Like, let me just see if I can fix this stuff. And you're also kind of
maybe
guarding
it'll
your own
go away.
emotions. So things get weird quick.
Yeah. Oh, that is a mess. And in case you're not like medically oriented, a hysterectomy, like Nicole was talking about, that's when they take your uterus out. So when you have a hysterectomy, one of the biggest things that will happen when you're going in and you have any kind of emergency in the postpartum period, you know, after you've had a baby, your uterus bleeds like crazy, especially after you've had a baby. So one of the biggest things that can happen, and Chelsea, you'll probably be able to talk more to that too, is they have to take it out, because if you take that organ out, you will bleed a lot less. But obviously that's a huge, I mean, you will not be growing babies inside of you.
Last step.
Yeah. Once you have had that done. And that happens. I have had many, many, many patients who, even if they survived, they kind of got to that point and they were like, oh, well, if we had known sooner, and they were like, I've been telling you, and you were just like, oh, it's fine. I'm sure it's fine. I'm sure it's fine. And then, you know, even at the same practice, I've had things where like I said something, they were like, we need to get you in this office like right now. Like, and mine was so minimal compared to them. And literally the only difference is just what we look like, which is mind boggling. Anyone else want to say anything? Go for it.
I'm Caleb. My biggest question about this whole thing is, one of the things that a lot of people don't realize is that nurses do a lot behind the scenes in order to gather evidence, even if technically speaking there may not be an order. My question is, like, you've got to be in an area where there's an ultrasound. Why is somebody not, you know, even if a CT is scheduled, why is somebody not doing an ultrasound? Because you can see a lot of fluid. You know, you've got...
They did 2 bedside ultrasounds.
Yeah. And we'll go through the entire court transcript of kind of the case that they brought. They did 2 ultrasounds and it did show a hematoma around the bladder. And when it got worse, that's when they took looking into it more seriously. But initially hours and hours before they did it, and they saw, like, you would think you would put together a patient reporting a lot of pain, bleeding like crazy through their catheter. There's a hematoma here. Perhaps we should put, 2 and 2 together, but that is not what happened. Very unfortunately. All right, let me see if I can find, so I'm just going to have the rest of you introduce yourself super quickly, and then we'll start going through and kind of looking at the case. Let me see. Nurse Mama, do you want to go next and just say hello while I pull this up?
Hi, guys. So I'm Vanessa, also known as Mama Nurse. I'm a mother of 4 and a trauma surgical ICU nurse.
Guys, I found fancier people than me, in case you can't tell. I'm going to find people that I sit at home and rant on the internet, and these people are doing the dang thing. So they're cool.
I'm Chelsea. I am an OB nurse. I do labor, delivery, and postpartum. And it's the only type of nursing that I've ever done. I'm also in graduate school right now to become a nurse midwife. And I have 3 kids of my own.
And I'm Scott. I have the Nurse Scott YouTube channel. And I have worked for many, many years in emergency nursing. And emergency nurses are notorious for knowing nothing about OB and delivering babies. But I'm back in school to get a master's degree to become a family nurse practitioner. So I'm going to have to relearn at least some of that. I don't think I'll be delivering babies, but we'll have to learn about GYN concepts and all that.
It's always a fun conversation with the ED.
Yes, yeah. You never know. I have come very close in primary care to delivering a baby. I was like, why did you come here?
Well, I think we only have that happen once.
I mean, I've done it, but I don't want
it only happened once in all those years. I thought we would in the ER. And actually, it was at Cedars-Sinai, where I used to work, that we actually did deliver a baby, where I was right there delivering the ER.
Oh my gosh. And Cedars-Sinai is where this case takes place, in case I didn't mention that in the rundown.
I've been gone for a while, and I can't speak to the OB department because I didn't work there. But I know the facility, and I know the culture of the corporate culture.
I did want to point out too that one other thing I wanted to do towards the end, because I never want to just leave these with like, oh, this is doom and like we can't do anything. I just wanted, one of the points of having this conversation is to raise awareness that this exists, even when you don't think it necessarily exists. And two, maybe we could all like, I have some things that I used to tell my patients of like, these are different things that you can, advocate, say to like help advocate for yourself more, in case you're watching this and you're like, well, this makes me just like terrified, so that we don't leave it. I mean, it is a very serious and horrible thing, but also there are, different phrases that will scare your healthcare provider team more than others. Maybe we should just use those, instead of other ones. And then to take it as like, yes, it is not, you are going to feel horrible when you do this. Like even like Nicole said, where she felt like, okay, like you said, it's okay. It's okay. I think healthcare is scary in that way, where you feel this weird complex. Like even as a healthcare provider myself, I've pushed stuff. I'm like, oh, well, I don't feel like this is right. But if you say it's fine, because there's some, other doctor standing in front of me telling me it's fine. So knowing too that it's always going to feel weird, but going with your gut sometimes is incredibly helpful, because usually our gut's right. And because you know your body best. Let us. And then Cal, did you introduce yourself yet?
Oh, I thought I did it earlier. But yeah.
You might have. My brain.
I'm Cal. I work in geriatrics long-term, a lot of short-term rehab. So a lot of the tools that are available at the hospital aren't nearly as capable for us.
Let me see. Okay. Perfect. And all of you can feel free to jump in, jump out, whatever your life does. This is very low key. Okay. We're copying LawTube on this. I appreciate all of you being here. Let's go through. I tried to highlight some of the parts that I thought were like of interest, but if any of you see anything else interesting, this is just to kind of familiarize ourselves with the case. That way, if we're at a coffee, like with a friend, we can just, when they're like, what's new with you? You're like, I have a lot of thoughts on something I need you to know about, and you can just drop it on them. Okay. That's how we're going to get the word out about these things and slowly change lives one at a time. This case, as far as I can tell, is they're going to actually take it to court next year in 2023. So this all takes like tons and tons of time. It's being brought by the husband, Charles Johnson the fourth, and also on behalf of their two children. The defendant is Cedars-Sinai Hospital in Los Angeles. It was an elective cesarean section. I've seen Kira's name spelled differently. Like in here, it's spelled differently in articles too. So if any of you know which spelling is actually correct, I went with the one that was largely produced, but this one is a little bit different, just to have it out there and to be known. So she went into the OR at 2 p.m. They put in a Foley catheter. That's the catheter that's going to go into your bladder. It should be draining urine. This is a standard procedure. If it's draining things other than urine, usually you have to start asking questions, because you're like, where is that even coming from? The delivery started at 2:30. So that seems pretty standard, I would imagine. Chelsea, I don't know if you think I don't think that's like the weird thing. I would imagine getting draped and prepped and all the things, half an hour, that's reasonable. Then the child was born at 2:33, which also just, I think, as a very different side note, shows you how quickly they get the baby out in the C-sections. Like start baby, and then we do other things. Because look, it started at 2:31 and baby's out at 2:33. The procedure was completed in total by 2:48. That's going to come up later. Basically, what the lawsuit is going to be saying is that this was a rushed C-section that led to a nick in the bladder. Is that like a normal timeline for a C-section to be done in like 17 minutes? Okay.
No.
Chelsea's saying no. Okay.
No.
How long do they usually
not
take?
At all.
Okay.
So like in my facilities, say it's like a 7 a.m. scheduled C-section. That's whenever they go back to the OR. So we walk the patient to the OR at 7. Babies are normally born between 7:36 is a very common time for a baby to be born at our hospital. If it's a scheduled C-section, just like, that's just the time. So, and then they are coming back into our room, usually between like 8 and 8:30. So this being like 17 minutes start to finish is is so extremely fast.
Mhm. It seems
If
fast.
everything is being like, if everything is stable, which it
Yeah.
was in this case, this was like
Yeah.
scheduled repeat cesarean. And just of note, with this being her second, there would have been scar tissue to get through, which is really interesting for getting to the baby in 2 minutes. Like, maybe she didn't have a lot of scar tissue. Sometimes there isn't a lot, but usually if you've had at least one C-section before, there's going to be scar tissue in all of those layers getting down to the uterus. And so getting there in 2 minutes and not an emergency is pretty interesting to me.
Yeah. And which probably would lead to like, oh, if I nicked something there. And I think a thing to realize is when you're after surgery, like the part where they're trying to close up, that's usually when the surgeon, that takes the longest. So I worked on after like open heart, where they would go after the kids had the open heart surgery. And that after they were done was always the longest period. And they were telling parents, and you would have to be there as like their nurse. You're like, this is normal. They're making sure that there's no leaks. Like we totally messed with plumbing, that things aren't bleeding. We don't want to sew you up before we make sure we check all of your guts, before we check all the things and make sure like everything is hooked up the way it should be. And so the fact that if they finished it up and did this so fast, how long could they have possibly spent looking to see like, did I nick your bladder? Did I, is all of this as it should be? Which it doesn't seem like that is normal. So at 2, so it started at 2:30. At 3, she was already out of the operating room. And like Chelsea said, usually that would take until 8:30, you said? So that's speedy.
Yeah. I mean, it kind of depends. Like sometimes it'll be like right after 8. It depends on, how clean it was,
Yeah. How much there was to,
Exactly.
How many inside parts were scraped and all the things. And so good at 3:04, she had skin to skin. They brought the baby, everything's fine. This was at 4:45. So this is 2 hours about after the baby was born. Kira's fundus was risen from +2 to +4 centimeters above her umbilicus. So what that means is your fundus is the top of your uterus. After you have your baby, you want your uterus to go down because that's where it normally lives, is like down in your pelvis. And your uterus needs to contract because we talked about how it's like really bloody and like just like a very, it's gushing all the things. It housed a human for a long time. It needs to tighten down and get back to its normal size, which is small, like this big. And to do that, they come and they mash on it. They feel where it is. And you want it to be below. You want it to be going down below the belly button. Does that sound right, Chelsea? That seems like what I sort of remember. Yes. You want it to go down, not up. Up is bad. Up, I can't imagine, you can tell me if I'm wrong, a situation where up would be not a cause of alarm.
No. Up is always concerning.
Yeah.
Even I knew that as an emergency nurse.
Yes, that's like a nursing boards question. I feel like they're like, it's at the line of the umbilicus. It's going up. You're like, nope, that one. That's the wrong answer. We don't.
It's interesting to me that we started at +2. Also, that's
also yes.
Especially with being as small as she is, I would expect to like at the highest be probably at the umbilicus, and so, but I wasn't there, so like it could have been totally normal. There are like there's a bell curve of normal, and it could have been just that, like her right after delivery, that was where it came out at. But that did kind of pique an interest for me.
Yeah. Yeah. And they're like, that's when if you've ever had a baby, that's when they start coming and they're like punching you like on your uterus, and they call it a fundal massage. But what they're trying to do is they're trying to like, yeah.
I'm just kidding.
It was awful.
I'm just kidding. It is the worst.
And they do. And but the point of them doing it is to be kind to you so that you don't bleed out, because if you push on it, your organ's going to be like, I hate this, and shrivel, because we want shriveling. Because if it shrivels, it's pushing pressure on itself, and that's how it stops bleeding, right? If you have a wound, you push on it so that it stops bleeding. We want you to stop bleeding, essentially. So this is, okay, then it says this is associated with a failure of the uterus to contract after delivery, a condition called uterine atony. Atony can also lead to symptoms like life-threatening conditions known as postpartum hemorrhage. What is usually the protocol, Chelsea, if it's not going down, other than to keep punching it?
you need to figure out why it's not going down. There's several reasons. Like, it could be that the bladder is filling up and not allowing for it to contract down, or displacing it upward or to the side or something like that. It could be because it's filling up with clots. That's like one of the more common, well, bladder is really the most common, but if we've ruled out that the bladder is not full, then a lot of times we see the uterus filling up with clots. And it's tricky because whenever you feel it, it is firm, and that's what you want. You want a firm uterus, not a body uterus, but it's firm because it's like just full of clots instead of liquid blood. And so that can be tricky. But the first step, you just need to figure out why are we rising? And like somebody said in the comments, a uterine sweep is an idea. They would be really wary to do that on a fresh C-section. But nonetheless, it needs to be figured out what is causing it, and then having that knowledge will help you to figure out what to do. Retained placenta exactly is another option. And if they do find that it's retained placenta, then they need to go in for a D&C.
And that's because your placenta is what connects it's kind of the lifeline between baby and uterus. So if the uterus thinks it still has the lifeline in it, because usually your placenta will come out after you have the baby, you deliver the placenta. So if it thinks there's still something it needs to hang on to, it's not going to want to squeeze down, because that would then cut off the blood supply to the baby. So your uterus is literally like, no, I'm not doing this right now. Like, we're still working on something, but you're not really working on it. And that's when we lead to problems, because we don't.
Sorry.
No, go for it.
Retained placenta is much more uncommon with C-sections because they are looking at the uterus. However, this C-section was done incredibly fast, so I don't feel like they were maybe paying attention to detail. But in most circumstances, a retained placenta is much more common in a vaginal delivery whenever we can't actually look into the uterus to see what's there.
And that's when they flop it onto the thing. If you've ever had a baby vaginally, they flop it onto the table next to you, and they just like stare at this alien organ.
We dig through it to make sure all the pieces are there.
Yeah. And you're like, what is, excuse me, what is happening? So her fundus is going up. Bad sign. Shortly before 5 p.m., blood-tinged urine was seen in Kira's Foley catheter. Would you ever expect to see a bunch of blood in a catheter after birth?
A bunch, no.
A little?
Sometimes they'll have like just some tinge, especially like right during or right after. And it's like from trauma around can just kind of create a little bit of trauma to the urethra or to the, the bladder itself. But if there is blood found, usually they will investigate that. If they can see it in the OR, they will investigate that to see if there is a nick or something like that. But if it's something that I find postpartum, if it's just a little bit, if it's just like a little bit pink, I might kind of, obviously I would let the doctor know, but kind of see how it goes, if it's getting worse or if it thins out and it becomes normal color, and then go from there based on the observation.
And I think, and then so at 5:20, and this is why I'm so grateful that all of you are here, because this gives so much good insight. I'm like, I think this is fine or not fine. At 5:24, so half an hour later, then it starts draining bright red blood. And I think everyone can probably speak to, from whatever specialty you're in, that if your Foley is draining, so your Foley is the tube that goes into your bladder. If there is bright red blood in it, that's no. Like that's never normal.
Right. Not a good sign at all.
Yeah.
And that's what I just wanted to say. The blood temperature is starting at 5.
Yeah.
So I would not expect it that far.
Only if we're trying to get a man's blood urine flow going, like after prostate surgery, and it's clotted off, then any color urine coming out is a good color. But normally, other than that, I would imagine no.
And women don't have
when it started at 5 p.m.
we're probably
too late to be just normal.
So I'm a little confused. So the urine was bloody. That's an expected outcome? You guys are saying?
No, I'm not saying expected.
Gross blood.
No.
Okay.
Yeah.
No, I don't mean expected. I just mean like sometimes like right at the time of delivery, there can be trauma to like the area, and it can cause like a little bit of tinge from like little capillaries being broken and kind of coming out.
So maybe this isn't them being incompetent. This was just something that
Until
This says that
5:30.
it's at 5. Right,
Gotcha.
exactly.
Gotcha.
This is
Okay.
this is
Okay.
way
That
later
makes
than I
sense.
would expect to see something like that. I was just trying to
Gotcha.
say, like, it's not a little bit at the time
You're right.
would be maybe something to investigate further, but I wouldn't have like 10 out of 10 alarm bells.
Gotcha.
Seeing it
Gotcha.
start
Okay.
hours later, I would be more like, whoa, what's happening?
Okay, because this
And
is a
then
whole
how-
new world. I don't know much about it, so thank you so much for clearing that up. I really appreciate it.
Yeah.
Yeah. And then how many alarm bells would you have if 24 minutes later it started doing like frank red blood?
I would be like, oh, I'd be like pooping my pants.
Okay.
And,
Okay. That's because that was my like primary care perspective too. I'm like, if you'd be like, I am just peeing bright red blood, I'm like, this is soon going to be not
even
my
at the
problem.
5 o'clock time, even at the
You're going
5 o'clock
somewhere
time,
else.
I'd be like, wait, what?
Right.
Yeah. Why is this starting?
What time
now?
is
At this
it? Like,
point, they should have been ordering like a KUB or something like that to see why it's bloody 30 minutes after insertion.
yes.
And the point of us kind of going through this and talking about this is to show that this was not like, oh, this person made a very simple mistake. This is like, I am not a labor and delivery nurse, and I'm looking at this and going like, there's something wrong here. You know what I mean? So that's kind of the point of us going through it and having other people especially look at it and say, that's an alarm bell. Like, because we've had a few by now, and you would think someone would have looked at that and said like, like that's not, I don't like it. 5:38. Oh, they put a new Foley catheter in. Foley catheter was removed for bloody urine. It was replaced at 5:30. Maybe thinking it's a clot. I don't even know why Chelsea, do you know why they would do that? Like just to see, like, let's just replace it. Let's see if there was a clot in the top of it, like instead of flushing it.
You know, I read that and I was like, I don't know what they think that they are going to gain from that.
Yeah.
Really. I mean, they could have flushed it or something.
Maybe they think it's old blood, but clearly it's not. I know. I know some of my attendings are like, that's old blood. I'm like, it's pretty red, dude. No. Just change the Foley and watch. It's not going to be out anymore. Like, still bleeding.
That's what I wondered. When I read it, I wondered, like, did some doctor just say, well, why don't you change it and see then?
Right.
That's really what I thought.
Yeah.
Because really, if it was a clot, then it wouldn't be draining anything at all. It would be, there would be no urine output.
Yeah.
Exactly.
Yeah. And if it's old, it's usually brown. Yeah.
Right.
Oh, well, I was going to say my experience with older men is that a lot of times, even just inserting a Foley, you can cause a lot of damage. Even with women, you can. But anytime there's bright red blood, especially with men more so than women, like that's a major issue.
Yeah. And you would think like replacing a Foley in someone who just had a baby sounds awful. Like I've had a Foley inserted after having a baby and it just was not fun. Like things are not happy down there. So like, why would you go and do more trauma? I would think you would only bleed more, but whatever. Shortly. So they replaced it as if this was going to magically solve the problem. This really sounds like one of those things where like, why don't you just put a new one in? Like maybe it'll go away, you know, like really? Maybe it'll just magically fix it. So they put a new one in, very shortly.
Cedars-Sinai is a teaching hospital. There could have been an OB resident and not an attending. And, you know, when in doubt, put a new Foley in and I'll talk to my attending.
Yeah. That happens.
Yeah. Are they still having an allergic reaction to the med if we put it through a different IV?
Yeah. Or is the allergy even real? I don't think it's real. I'm like, well, I'm not giving it.
It might. Yeah, it might be the site. I'm like, okay, let's talk to someone else. So at 5:38, Kira's fundus continued to be at +4. So it's gone from belly button. It should be by now like living a lot lower in your pelvis. Okay. So it's above 4 centimeters above the belly button. The fact that it has not shrunk down 3 hours after birth, not good. There should have been like a lot more, in my opinion, going on here. And there was still a lot of frank red blood, just means like bright red blood, not tinged like we were talking about. Tinged is like, oh, there's like a drop, you know, frank red blood is like, oh, that's blood coming out of your catheter. Still present in the Foley. 7 minutes later, Kira's Foley was draining complete red blood, which seems terrible, like to me.
Yes.
If it
very, 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 very
That sounds
Not
like urine tinged blood instead of blood tinged urine.
exactly.
Right.
Exactly. Yeah. Which is never normal ever. 7. So we have that. And this is where they did the first bedside ultrasound, which seems like, I don't know, but well, that just seems like not quite. I would have gone maybe for a little bit something harder hitting, but a bedside ultrasound. A ultrasound is going to be able to show you fluid that collects around your organs. They're very helpful because they can come to your bedside and do it right there. 6 centimeters, fluid filled collection behind the bladder, anterior to the uterus. So like kind of in between, compressing the bladder, suspicious for a large hematoma. Hematoma is a collection of blood. Urotonics, Pitocin, and Cytotec were ordered for apparent uterine atomy. Is, remember, where your uterus won't clench down on itself to stop its bleeding. And I'm going to let Chelsea explain those other words.
The meds?
Yeah.
I'm sorry. The Pitocin
Well,
and
they
Cytotec?
they'll just make it stop, right? Try to make it stop bleeding.
Yeah.
Contract.
Yes. So the Pitocin is just a synthetic form of oxytocin, the hormone that does lots of things in your body, one of them being making your uterus contract. And Cytotec also makes your uterus contract. It's actually a GI med, but we use it off-label in the OB world all of the time. And it does irritate your uterus and make it contract. And so we usually give that rectally, and the Pitocin is given IV.
And if you've had a baby, you might have gotten Pitocin in your leg after delivery. I had that with both of my kids. They come over and you kind of don't even remember sometimes because you just had a baby, but they'll stab you in the leg with it. And that's to help your uterus contract because they do not want this to happen. That is when the defendant, Dr. Naeem, was notified, hey, this person is bleeding. There's a collection of blood here. Kira was given Dilaudid for pain, which is a pretty nice hardcore pain medicine. But it's interesting that they just kind of gave her pain medicine, but didn't do more looking into it.
Yeah, I found that really disturbing.
I'm
just glad
be
you're
quiet.
Managing that, but
exactly,
is that just gonna make her fall asleep? I'm just
exactly like you're going to okay, now so you can't, like, if anything in that situation, I don't want you to ever be in pain, but I want you to be able to tell me what is happening. And Dilaudid's going to make you very tired.
But is Dilaudid normal for post-pregnancy? Because I've had 4 children and I've never been offered Dilaudid.
Not even close.
We don't give
That's extreme.
Yeah.
That's very
okay.
strong.
So that does kind of just seem like a cover up, like hush type of.
Right.
But then again, if she was in a lot of pain and they didn't give her anything, we would be sitting here saying, why didn't they give her something for her pain?
Yeah. That's a very good perspective.
Yeah.
And you are
I don't
taught
think a little dose of Dilaudid
is going to long
what's
term.
her vitals in this situation? Because you're giving boluses. I'm so concerned about this lady already.
Well, this is one thing that I found frustrating. I printed out the complaint and went through it. I kept on having to remind myself that this is, number one, this is the plaintiff's complaint. So this is Charles's side of the story.
True.
And from his perspective, which is important. And honestly, this would be the perspective that I would want to see, especially first. But we don't have the medical records. They put in little nuggets of the medical records, as you're about to see with some labs and these notes. There will be a few things that are in here that us as nurses can be like, they got that straight out of a nurse's narrative. But it's not like the full medical record. And I have 17 notes on these pieces of paper that are like, but what is this? What were her vitals? All those things.
Right. Okay. So no trends. They're just giving general numbers and you have to just kind of take it as is.
Yep. We're about to get into some blood work, but we haven't had actual, and we will get to vitals when things go really poorly. But that will be interesting, I'm sure, when they take this to, so what basically has happened is he just presented it to the court in the beginning of May, and it was assigned a judge. He has gotten someone to be, because he's bringing a case along with his children, so they needed a court appointed representative. So those are being assigned, and then the case isn't going until I think 2023 is when it's actually on the docket to go to see is this going to, how is this going to proceed? So we'll keep following it. But this is kind of this is basically what he is writing, what he submitted to the court to say, look at this. But Chelsea's totally right that this is his, this isn't the subpoena of the medical records. This is his story, essentially, that he wanted to get covered. And then Michael asked a good question. Is this all nursing intervention at the time, or are these actions directed by an MD? These would have been as soon as, I'm assuming that they ordered an ultrasound. Nurses usually can't just pull up an ultrasound and do those. You can't change a Foley out usually without an order too. So there was some provider overseeing this, at least somewhat. Does that sound about right?
Yes.
Yeah.
And especially at a hospital like this, that is a teaching hospital, and they had residents. So hospitals like the one that I work at, it's smaller, and we don't even have doctors there all of the time. And so a lot of stuff is nursing driven. We have a lot of standing orders, and a lot of the doctors put a lot of weight on on our assessments of situations. But in a hospital like this one, there are a lot of times that nurses, labor and delivery nurses, will say that they rarely even get to do a cervical exam on a patient because the doctors are that there in the care. So,
and they're usually floating around, at least at my experiences on kind of labor and delivery, is everyone's kind of in the hall. It's easy to kind of poke your head out, and you would do that if your patient's fundus, if their uterus was not contracting, I would imagine immediately someone would have been notified. And I think we'll see that as it comes out in the course cases, that yes, the nurse probably immediately did, as soon as they found, it's not shrinking. That would have been one notify. I'm sure they notified that, hey, the Foley, it's draining blood. So it seems like I would imagine there was conversation. And then, so they gave her Dilaudid, which is for pain. And then they also gave her a fluid bolus, which makes me think that her blood pressure was probably lower than they wanted it to be, or her heart rate was going up, or both, to try to see. And maybe they were thinking we could flush this out. If we make her pee more, maybe it will get better because it's going to flush whatever is in her bladder out. And then we get her first labs afterwards at 6:12 p.m. So remember, she gave birth at 2:30. White blood cell count, normal. And white cell blood, you would expect to see, even if it was a little abnormal. This first labs are actually pretty normal. Your white blood cells count is going to be a little bit high after you have a baby. Your red blood cell count, your hemoglobin, and your hematocrit are probably going to be down a little bit because you just had a baby and you were bleeding. But these are actually fairly normal. Her hemoglobin's 9.2. It says normal is 12 to 16. I would say for after having a baby, 9 would be normal. I would not freak out about that. I don't know about you guys, but I would say most of these would not scare me if you brought them to me. I'd be like,
Chelsea,
and the note that I made about, go ahead.
Yeah.
You might know this, but usually I know for surgery, a lot of times I'll be doing lab work kind of alongside surgery. Do you know if there were labs either prior or during the C-section?
They definitely would have had pre-op labs.
Yeah. When you go to have a baby, as soon as you walk in the hospital, that's the first thing they do. At least in my experience, both places I've had, is they've drawn a type and screen and then at least a CBC and some kidney liver
I'm talking about do we know what those were or no?
It doesn't say in here, but I'm sure we'll find out. But we do have a comparison a few hours later, unfortunately.
Right. A lot of
so
these
they text her.
I would have. No, go ahead.
Yeah, want to see what was her baseline. What was her normal blood pressure? Because what are we comparing it to? But these in itself, they go in here and they talk about it's abnormal, it's abnormal. The thing you actually want to watch, and this is pretty much throughout all of healthcare, is one set of vitals, just like everyone was just asking, is never helpful because you need to compare it to something because maybe this is their baseline. What are we looking at? We need a trend to see how is this moving. A picture, a snapshot, is never helpful. They ordered, so we'll kind of come back to the vitals in a second because they're going to become very telling. 6:44. So we're still doing this thing. It's now 4 hours after she has had the baby. They order a stat CT of the pelvis, which is a hardcore X-ray that's going to be able to see in much better detail than the ultrasound, what is happening and where. And a CT urogram was ordered. That's like a CT of your, I would imagine, uterus. Maybe. Oh, you're muted. Let me see if I can unmute you. I cannot.
Sorry, I was off with the tab. The bladder. It would be of the bladder.
Okay. Perfect. See, this is why we have friends.
That's what they would be looking for, is for if there was a problem with the bladder. I mean, they would be able to see other things as well.
Yeah. Yeah. So they ordered it. It did not happen. The records documented intractable abdominal pain and frank blood per Foley catheter at this time as well. Intractable means it's not going away. Horrible. Like you can't fix it with things, you can't reposition and make it better. It's there and it's not going away. The order also state, please add imaging, i.e. CT abdomen pelvis with contrast if needed to fully evaluate the patient's post-op abdomen pelvis. High concern for pelvic hematoma, so a collection of blood in the pelvis, but uncertain regarding injury to bladder and uterus. So they knew at this point, they were worried that something was going on. And basically they were saying, you can do as much imaging as you need to while you are there. If you see something else that makes you go, I'm worried about this also. So they clearly knew at 6:44 that they were worried about something finally, even though we would have been worried before, but what do we know? At 7, so it still is happening. Now it's 45 minutes, even later than that. Dr. Sharma noted that Kira had not had any urine output after 5 p.m. Odd. You should, especially after a bolus and after having a baby, you pee a lot because you had this whole other circulatory system that was keeping a human alive, and it's all being rerouted to you. During your surgery, you've had a lot of fluids, but you pee like crazy because your body's trying to get rid of all the excess fluid. So to not see someone peeing after they have a baby is very, very odd. And you have to wonder, like, where is it going? Why? This is odd. So they decided to do another ultrasound at the bedside. Still haven't had that other test that would tell them more. Showed a hematoma had gotten bigger. So the collection of blood is getting bigger. Kira and her husband were told that although the hematoma appeared stable, there was concern regarding blood in the Foley with a little to no urine output. And that they would abstain the stat imaging of the pelvis and everything to make sure that they're like the bladder and the uterus were fine. Obviously they weren't, because things were getting worse, as they just saw. More fluids were provided via IV infusion. And then we have our labs between 7:35 and 8:01. So remember, our white blood cell count fights infection. We expect it to be a little bit high after you have a baby because your body's like, what is happening to me? It was at 11 and now we're at 21.5. In the span of, 2 hours? So, an hour. Okay. So in the span of an hour and 15 minutes, your white blood cell is through the roof, meaning your body is trying to fix itself because it knows something is wrong and it's sending its little army to try to fix it. That's a huge jump. I don't work inpatient anymore, but if I saw a jump from 11 to 21 in an hour and a half, I would poop myself. That's not good. Red blood cell count, abnormal, that's way lower. Hemoglobin is how much, that's what we usually look at to see how much like red blood cells you have, like how, that's where we're going to try to figure out, like, are you bleeding? And it went from 9.2 to 7.6. 7's usually when you like transfuse, but that's a big jump for an hour and a half. That is a huge, is that normal in labor and delivery? Because if my heart patient did that, I would, no.
So I would only expect to see it if we knew that the patient had hemorrhaged. You know, if she's hemorrhaging and we're getting her labs, then I expect to see that drop. But no, that is not, it's not a good thing. It's just, it's definitely.
I don't understand what they're waiting on imaging for here. I'm a little, I don't know what the imaging is going to show them that they can't really see right now. Are they waiting for a definitive diagnosis that she is bleeding? Because everything is saying that she is. Once you get in there, you can figure out where the bleeding site is, but I don't think the scan is going to change her presentation. And she's getting so much worse so fast.
Right.
Yeah.
Exactly.
Jeez.
And so a lot of times they'll be able to go in, like Nicole was just talking about, you don't have to necessarily know what's wrong with people. And sometimes they'll go in and it'll be like an exploratory whatever. And that's what they'll call it. And they go in, basically cut you back open and figure out where is this coming from. And this would have been, as we'll find out, wildly clear, like as soon as they got back there. But it's like, if you know someone is obviously bleeding and it's coming out through your Foley, like we know where it's coming from. So why wouldn't you just go fix it?
Right.
Like, why? At 8 o'clock, Kira was seen by Dr. Churchill. She had still only produced little to no urine despite having been giving fluids at this time. So then it's like, where is this going? Kira's hemoglobin and hematocrit had been noted to drop. Her heart rate was tachycardic, which just means her heart rate's going fast. If you're losing blood, your heart needs to get blood to its organs. So it starts going faster to try to make up for the fact that the pressure is down, if that makes sense. Kind of like a hose. If you have like a lot, if it's really slow, you're going to start trying to push it out really fast just to make the volume the same. Estimated blood loss was about 1,500 cc's. So that's 1.5 liters. So if you think of a 2-liter bottle of Coke or soda, 1.5 is a lot. I don't know how much do you usually lose when you have a baby? I feel like maybe 500.
Maybe.
Yeah, it's a good question. It actually our parameters for hemorrhage have changed recently. It's considered a hemorrhage if you lose more than 1,000. Now we used to say 500 for a vaginal delivery and 1,000 for a C-section. Listen, I don't want my patients to lose more than 500.
That's a lot.
So. Yeah. I mean, I don't want them to lose more than 300. So it is a ton. That is a lot of blood to lose.
Yeah. And usually that's over the course of like a day or so, as you're not like still within, this tiny time frame.
And the body does, the body prepares for this, but we still don't want to lose that extra that our body gives us during pregnancy.
Yeah. Anyone losing 1.5 liters of blood, this problem. That's not good. This suggests symptomatic. So she's feeling it. Acute blood loss, AKA this is happening rapidly, not over a long period of time. Blood loss, anemia. So she doesn't have enough red blood cells. Therefore, she can't oxygenate her body. And decision was made to proceed with 2 units of packed red blood cells, which is not like a wild amount. Basically, they're slapping a Band-Aid on it. They're saying, we don't know why is this happening, but like, let's just give you some red blood cells, like, and that's going to make your hemoglobin come up and that'll make me feel better. Like, without looking at the first question. This is now getting into
giving me nighttime effort. Okay, so this is daytime where a lot of
nighttime
people are
effort.
available. The surgical team is there. This isn't 1 o'clock in the morning. No skeleton crew. Okay.
No, this was all happening during the daytime. This is daytime effort. The first question, at least that I was taught as a nurse practitioner, was if you have bleeding, the first question is where and why. Because you have to fix the where and the why. You have to fix the hole and the leak before you just slap more blood at it, because it's probably going to drain out the same hole that you already have. So Dr. Naeem then came in. So she got the packed red blood cells at 8:41, which and then they ordered fibrinogen, but not until 11:21. Fibrinogen will help you clot. That wasn't ordered till later, so she's still bleeding. 8:47, Dr. Naeem was at the bedside meeting Kira in the PACU. So I don't know if they hadn't evaluated her before that. I would imagine they would have had to. Continued to have bloody urine, had an abdominal hematoma, abnormal hemoglobin of 7, so is just dropping the amount of blood that she has. And then her heart rate was consistent with tachycardia, and then she had a possible hematoma. I wonder if that's going to, he probably said like, oh, she might have a hematoma. I'm sure in their actual notes, she has she has one. They did an ultrasound and they know she did. So this is one where you don't want to communicate to a family member that something bad is happening. So you start using words like possible and maybe.
Likely, probable.
Exactly.
Yes. Very, very, very gray zone.
So they told me, you probably have a hematoma, when in reality, they're in the back room going, oh, shoot, like this lady has a hematoma. This is happening. Much better, in my opinion, to just, if you ever have questions as a patient, just ask. And you can literally say, like, just please come, like, tell it to me straight is one thing that you can say, that I've had patients say, that I've said to people. And I'm like, even if it's not good, like, just tell me what the actual situation is, because it's so much more helpful than like, especially with serious things. People don't ever want to be like, hey, like, I'm worried you're going to die, like, because of this, like, this is serious. And learning to have those conversations, it's a very different conversation, right? Like, hey, do we maybe want to, like, we might do a hysterectomy. Like, what do you think? Or like, hey, you might die. You're less likely to do that if we take out your uterus. And then it's much more of an informed conversation versus Nicole, where you wake up and they were like, oh, we thought it would be fine, but actually we took that out. That is much more shocking and not fair. You know what I mean? Like, communication. So just ask people, tell it to me straight. And I will ask my patients, sometimes I will be like, how, like, I want to be able to tell this to you. It's not going to be comfortable or happy news. Like, do you want me to wait until someone's with you? Or how do you want to have this conversation? Or do you want me to sugarcoat it to you? And some of my older people, they were like, just sugarcoat it to me. I'm like, there's a possibility that things will be fine. And they were like, that's great.
Hey, Liz, I see a question that's an excellent one that could go right here.
Perfect.
So man of culture says, new nursing student, what would have been the best course of action for the RN to do?
That's a great question. Thank you for finding that.
Yeah. Any thoughts?
I would say go if they're not getting my best labor and delivery nurse heart here is hopes that the nurse in the situation was just like beside herself with what was going on. And so I would say, like, just go up that chain of command. If it's a resident that you're working with, go to the attending. If the attending isn't telling you what you want to hear, then go to the section chief. Keep on going until you feel like your concerns are being heard.
I get
Someone
the charge nurse
rapid
involved.
Response
like,
too. Rapid response.
Oh, yeah.
ICU get there. Like,
that would
fast.
be really good.
Even if the customer's not per the attending, we have to show up and assess it. And if we don't think it's a good situation, we just take over.
Mm-hmm.
Yes. And I have said, I have told physicians before, hey, I'm bringing you this concern and I hear that you are not concerned. I'm going to call a rapid response then, or I'm going to do this because this is how I feel that the patient is in danger. And sometimes if you let them know, like, this is going to be my next step, they will say, okay, I'll come in, or whatever.
Mm-hmm. Yeah.
And at no point did it state. Right. At no point did it even state, Chelsea brought up a good point, that a rapid response was called or anything like that. So it seems like they were just handling it kind of on the hush, and more people should have been involved in this for sure.
Absolutely. And you can get your charge nurse involved. You can go find that senior person on the unit, like that nurse that you trust, and you can yank them in and be like, even though this is not your patient, like, I just need to tell you what's going on. Find people. And when you're orienting, find those people. You know what I mean? Ask your preceptor, be like, when poop's hitting the fan, who are you going to go and get help? You know what I mean? So you could go to them.
It's intimidating.
Oh yeah.
I'm sorry to talk over you. It's hard with the delay.
No, you're totally fine.
It's really intimidating. We had a situation where in the ER, we had a patient in the psych ER right there next to it, like right there, screaming and for hours screaming and bloody murder and all this. And I actually called the vice president of nursing after talking to the house supervisor, and I'm like, this is not right. This kid is suffering. He could be given something to calm him down, So, but I was shaking, when I was on the phone, because I'm like, I'm going all the way to the top with this one. How is this the hill I want to die on? So check yourself and check with other experienced nurses, and then if you have to, call the administrator, call the president of the hospital, and say, look, somebody's going to die here. Someone needs to do something, and I haven't gotten anywhere with this person. It's hard.
Scott, you make a good point. It's always every time I do that, like, even, as long as I've been doing this, and, I am the charge nurse, and I still am like, shaking on the inside, like, gosh, dang it. Like, what am I about to get myself into? But, at that point, it doesn't matter, because you are just doing what is right for your patient.
And if you just frame it like that, I'm just trying to do what's right for the patient, I don't think anybody will fault you. They might be mad that you overstep, but every time someone's overstepped and I've been mad, they've proven me wrong. So I
Mhm.
always go in there with, you might think it's nothing, just go through the systems and
Yeah.
just ensure this person or the group that you're taking their concern seriously. But it's all for the patient. So as scary as it is, every nurse that tells me, can you just come up here? When I come up there, it is for the right thing and they're always right. And that's why I just come now. I'm like, I'll be right there. You don't have to explain anything. If you tell me
Yeah.
she doesn't look good, that's enough for me. I'll be right there.
Let me
And
come
sometimes
see.
there's not a more senior nurse, like someone in the chat just said.
Right.
That's
You know,
very
when
true.
staffing is so much turnover in staffing. Sometimes you're a
Mhm.
new grad and you're it, but you just have to. And you can apologize later. So look, I'm
Yeah,
new. I
exactly.
panicked. Try to walk it back. But I'd rather
Mhm.
make a mistake in that direction than not saying something and having a bad outcome.
Yeah.
Mhm.
Yeah,
And
you can
Boho,
talk to me later, but this lady dying is kind of a very permanent thing. I can't have
yeah,
that. I wouldn't want that
exactly.
on my conscience.
Exactly. And Boho, that's another good resource, is the house nursing supervisor.
Yeah.
That is someone else that exists to get you some help in those situations.
I
But
do have one last question before I go. And Nurse Scott, you might know this. Do they do 12-hour shifts at Cedars-Sinai, and is it different for doctors?
They used to do 12-hour shifts when I worked in the ER. Different units may have different rules, and I've been away several years, so it may have changed. Let's see, I'm not sure if I'm the one to answer this, but I know residents are limited to how many hours they can work, but it's like 100 hours in 2 weeks, and that can be distributed anywhere. You can work 50 hours one week and 50 hours next, or 70 one week and 30 the next. So yeah, that's always a question. Are the residents awake? Have they had sleep in recent history? It's a good question, and I don't know that there's a blanket policy, and I don't know what it is all these years later. Good question though.
Well, I gotta head out.
thanks for being here. Bye.
Bye.
And just to go backwards, a rapid response, in case you are not a healthcare, is when you basically can send out an alert to a team, and the ICU, a few ICU nurses will show up, like one or two, and it pages the entire team of usually like healthcare providers, so that basically it's what you do if you're like, my patient is declining, I need help like right now. This is not a code yet, they're still breathing, but I'm very, very worried about this, and this care needs to be escalated, and it needs to be escalated quickly, and it gets people there very quickly. So and I have also, Chelsea, found a lot of success with being like, well, I'm about to call a rapid. So since you're here anyways, like, would you like to just do what we would do if we called one? And then they're usually
That
like,
happens.
no.
I mean, people, that's what rapid
yeah.
response is for. I don't know when it was
Yeah.
created, but I remember when I was a G and they explained that people were dying and family members were saying, I've been trying to tell you guys this all day. So this is the system. I don't know if every hospital, I thought every hospital had to have a rapid response team, but I don't know anything about OB and I don't know their procedures, but medical surgical, they have rapid response.
She's still in the PACU, I think.
Yeah.
Which is
from
even
all of
weirder.
this. Yeah. That, because a PACU, usually places like the PACU and the maybe the ER and the ICUs, like you don't have that because you are that. Like you are
the anesthesia,
the higher level of care.
Maybe that's why everything kind of around
very
there.
odd. Very odd. A mess. So it's 9 p.m. She had her baby at 2:30. Remember, she's holding her baby, where she remained and still has not been transferred out of the PACU. Her heartbeat is very high. At 10:44, the CT scan that had been ordered stat 4 hours earlier still has not been done. And the record reflects that it doesn't look like it ever was done. At 10:55, the nurses notified the doctor that Kira's blood pressure was in the 70s over 50s. So normal, we say like that's low. 120 over 80, so that's kind of where we're looking. After you have a baby, might be a little bit low. 100 over, 60s, 70s over 80s is like, we might be calling a code. Like I would reach for the code button instead of the rapid response button, because I'm like, oh, you can't perfuse your body. You can't pump blood if you have no blood pressure. And 70 over 50s is high panic. That's not like that's you yell out in the hallway, their blood pressure 70/50, and suddenly there are a lot of people in that room with you.
Right.
Exactly.
Dr. Churchill and another doctor were at the bedside assessing Kira, even after changing the blood pressure cuff. So this is mind-boggling to me that they were
love doing that.
Put a different.
No, did you check the leg though? I'm
cuff
like,
on.
dude, it's low. You sure you checked the left arm? What about the other arm? I'm like, dude, just come over here.
It's like rearranging the deck chairs on the Titanic.
It's crazy.
And then, so it goes up to 82/53, which is still considered an emergency, like emergency. And after you take the blood pressure, it's almost always higher the second time because your arm's a little bit ticked off. 82/53 is still not a life-sustaining blood pressure. This is still not good. At approximately 11:25, Dr. Naeem was notified with a concern for active internal bleeding, which I thought we had established at 3 p.m., but apparently we had not. Now it's 11:25 at night. Despite there being blood in the Foley, no urine output, nor abnormal labs, symptoms suggesting acute blood loss, and enlarged hematoma. It was not until approximately 11:30 and thereafter that a surgical discussion was held and a consent was provided for surgery. So, like Nicole and Chelsea, everyone was saying earlier, like, why did we not just go in when we said, why would we not just go in and see where are you bleeding from? We had to wait half a day to get to this point, 10 hours. 11:42, Dr. Churchill. So I'm really interested to see what did her vitals drop when we eventually get to see that, or why all of a sudden did they see the urgency that happened here? Because to me,
I don't get
it not have been in this situation like an abrupt. This would have been a slowly decompensating thing. Go for it, Scott.
Well, one thing, were we talking about Dr. Churchill being there earlier or just now? Because I think I read that she was.
Churchill's just coming in now.
He's just coming in now.
And she's the chief. That's why things started moving.
Oh,
Got
okay.
it.
That explains.
That is very helpful.
Allegedly.
That is very helpful. So they're there.
And it does say, I'm sorry, I just want to go real quick. It does say at 10:55, the nurse notified the doctors. And so I'm wondering if the nurse said, okay, that's it, I'm going to Churchill. And then Churchill came.
That would make a lot of sense, saying that there was an active bleed. Yeah, like basically going to the head, the highest level you can page to, and being like, this is the situation. And then we see things. 11:42, Churchill and Sharma were at their bedside. She was feeling more groggy than before, as would be expected if you are not sending blood places. Heart rate was at 120s at rest. Normal is like 60 to 100. And her blood pressure was 90/70. That's still not great. Dr. Sharma performed another ultrasound, found expanding hematoma and now free fluid. So basically her abdomen is just filling up with blood. And it's not bound by like an organ. It's just going all over. Dr. Sharma and Dr. Churchill recommended taking Kira to surgery to identify the source of the bleeding. Yet Dr. Naeem, who was also at the bedside at this time and in the face of these abnormal findings, as previously set forth, wished to continue expectant management at this time.
I don't understand that. I'm not saying that he's wrong. I'm just saying that in the face of everything that is changing, in the face of the trends and her transitioning, her heart rate increasing and her blood pressure, dude, let it go. Let it go. Yeah. Just let it go.
Yeah. And you'll see this sometimes where it'll be like it's your reputation. If everyone else suddenly comes in and is like, we need to take her to the OR right now, the person who like the new eyes are going to be like, what are you doing? And the person's like, I think it's really fine. Let's just keep watching.
I've been here all
you don't
day.
want
You just got here. Calm down. She's good.
Yeah, exactly. Where other people are like, what is happening? Shortly thereafter, they initiated a massive transfusion protocol of packed red blood cells. So remember, before she got 2 units, which is like 2 little pouches. Massive transfusion is you just start dumping those in, and it's a lot.
What's that? 4, 4, and 2? What's a massive transfusion? OB nurse, can you help me?
Yeah, it's usually 4, 4, and 2, and then we're getting fibrinogen as quickly as possible.
Okay. Oh, wow.
And can you explain what 4, 4, and 2 is for our non-healthcare people?
4 PRBCs, four
Packed red
units.
blood
I'm
cells.
sorry, 4 units of
No, you're
packed.
fine.
I'm sorry, packed red blood cells, 4 platelets, 4 units of platelets, and then the
2 of
1
plasma, I think.
yeah, 2 of plasma, and then we also want fibrinogen, but it takes long at my facility. It takes longer to get, and so they're supposed to thought if OB is the one who's calling for the MTP, they're supposed to thought automatically, but they don't always remember to do that.
So it's a lot more than the 2 that she got earlier. Basically, she's getting this plus so packed red blood cells is just the red blood cells, and now she's getting 4 of those instead of 2. She's getting plasma, which is kind of the fluff in the blood that is just there as fluid. She's getting platelets to try to help clot, and then fibrinogen to make her clot. Mm-hmm.
And then the thing about the MTP is that they will continue to bring that blood, and you will continue to give it until you feel like the situation is managed. And so like one of the things about an MTP that's really important is that you actually have to tell the lab to stop doing this, or they will just continue to give you blood.
Mm-hmm. And yeah,
now in your experience, is there always a surgical intervention when you give massive transfusions like this, or is it like we're going to give blood and then we're going to hang out and see what happens?
No. If we're doing an MTP protocol on somebody, then they're going to the OR, and it's an emergency.
That's the same in my experience. Like with trauma patients that come in, we're doing MTP and then they're going straight to OR.
Gotcha.
Stabilized to get you there. Yeah. I think that would probably be the case most of the time, unless you were dealing with like liver or kidney, where you're just trying to, your body isn't producing it, so you're shoving it at. That's where my background was for that. But I mean, everything else, I would imagine, taking the uterus out if necessary, because that's our bleeder. Going to Boho says it's usually in the OR looking for the bleed, so you're transfusing while they're pumping it in, while they're also looking, just to try to keep you alive until that point.
Exactly.
Kira was taken to surgery at 12:30 a.m. Remember, she had her baby at 2:30, and we started seeing issues at like 3. So at 12:30 a.m. on April 13th, during surgery, Kira was found to have 3 liters of blood in her abdomen. Humans only have 4 liters? 5 maybe? 3 is a lot of what we have.
Yes.
Yeah.
That
a lot of what you have total, like in your whole body. And if it's all just, that would just be so incredibly painful. And obviously, that's just horrifying. That's a lot of fluid in your abdomen. Kira did not survive the ongoing massive blood loss and was pronounced dead at 2:22 a.m. And the autopsy stated the cause of death was due to hemorrhagic shock. So basically, you did not have enough of a blood flow to your whole body due to acute hemoperitoneum. So something wrong in some organ.
That's such a long time. That's such a long time to bleed out and watch your wife bleed out and just sit there and people are telling you that is traumatic.
Oh my gosh.
I'm just picturing him just sitting next to her and being like, hey, she's still bleeding. It's fine. Everything's fine. And she's still bleeding, and she bled that long and she died. That's so sad.
It is so, so sad. And this kind of just goes back to, we don't listen to people. You know what I mean? And we're even less likely to listen to people. 3 to 4, if you're Black, you're 3 to 4 times more likely to not be listened to and to die when you're having a baby. And that'll be in places where people will swear up and down, like, oh no, like we don't have any of that.
We're inclusive.
Exactly. Like, I don't see color.
Yeah.
Well, the way,
and then
let me just chime in a little bit, because we say, what we say is we treat everyone just the same.
Yeah.
You come in here, it doesn't matter if you're black, white, green, purple, we treat you just the same. But the thing is, different cultures, really what they are, different cultures have different ways of being ill and expressing discomfort. And so the 2 that were actually at Cedars-Sinai that were the extremes were Russian immigrants. Were very, I'm going to say, demonstrative. When they hurt, everybody everyone knew about it. And Asian Americans, which just would, have an arm hanging off and they'd be like, no, I'm okay. So you'd have both extremes. So when we say we treat everyone the same, we treat loud cultures the same as other loud cultures. And that's a stereotype I don't want to make about the Black culture, but there is something like the angry Black woman, angry Black man, and Black people talk loud, but some people do. And so when they say, well, if it were a white person, making all that noise and being obnoxious, we would have treated them just the same too. And that's not what this means. That's still not right. I don't know if I put my foot in my mouth or not, but I'm trying.
No, I know what you.
No.
I know what you're saying because,
From this side, we think I'm treating everyone the same. If you're loud and obnoxious, I'm going to treat you like a loud and obnoxious patient and try to shut you up. But what happens is there may be certain cultures that are more loud and obnoxious as we define it
and it doesn't mean anything other than that's just a different communication form, and it needs to be listened to in the same way. Yeah. I saw that a lot in North Carolina. Other providers would come to me and they were like, oh, you know how she is though, she's just loud. I'm like, but that's not, no.
Doesn't mean she's wrong.
Yeah, exactly. You don't like the way she phrased it. She wasn't speaking the same words that you were using. She was using different slang. That does not make it anything different than you, like Nicole said, oh, you have dreads. Oh, obviously. I mean, that means that you can't be trusted about anything. You're
when I come in there, they're like, what do you do for a living? I'm like, I'm going to keep hearing this practitioner. Oh, really? I'm like, yeah. And my husband's like, why are you so quiet at these doctor's appointments? Because I don't want to be the loud Black lady. It's just, I know that that's what some people assume. So I go the ultra way and I'm quiet and I don't ask questions. And my husband's like, yeah, but look what resulted of you acting that way. You ignored what you felt was right and it resulted in this. Not that it was my fault, but now I'm more myself at my appointments. I don't know what this is. I don't like this. Can we investigate this more? Than everything's fine. I'm the perfect patient. I just want to make sure that you don't judge me the way you're judging me anyway. And I definitely learned that after my third kid.
Oh, for sure. And I have literally had other providers be like, she was really well behaved. Like a dog. She was so really well behaved. She speaks so nicely. She was so nice and well behaved for a Black woman. And you're like, jaw on the floor. And then you have Karens coming in, little white Karens, and they're coming in and they are just being like a hell demon. And you're like, oh, what a Karen. And you're like, and you would never think twice if I came in there and I raised hell because I was in pain and it would be looked into. It would be like, oh, let's take that seriously. And that's kind of what we're trying to talk about here is there's so much underlying. Go for it, Scott.
Something interesting you said about, wasn't she well behaved, for a Black woman? The thing is, I learned this early on because I went down to Atlanta for some non-medical kind of stuff, and they speak their racism out loud. And I'm from the Midwest. We may think it, but we don't say it. And so when you said North Carolina, so where I'm from, we may have said, she's such a good patient. She's just a really good patient, but we would never say that part out loud, but we may be thinking that. Very different across the country. They just wear their racism on the sleeve down in the South. And I guess that's easier to pick them out,
This is true. And that was supposed to be such a special day for her and her family.
Exactly.
And he lost his wife. The children lost their mother. It's just so sad. And it happened such over a long period of time, but very, very short period of time also for the family. But I could not imagine she's holding her baby. You think everything's fine. And then it's not looking too well. And it's not looking too well. And then your wife goes to surgery finally. And then she doesn't come back from the surgery. That's so sad.
Yep.
Did they ever explain why the other doctor didn't want her to go? Was there some sort of, are we missing a high risk factor or?
No. So I think that's hopefully I hope that'll come out in discovery. You would have to imagine that will be the one physician was, which one was it? Dr. Naeem they did do a complaint to the Board of Medicine, and they did a disciplinary action where basically they temporarily revoked the license, but then they immediately got it back.
Got it back.
And they no longer have residence.
Oh,
that was the punishment.
So that's a slap on the hand. They don't even do that.
Yeah. Okay. Yeah. So they had to do, I think, 40 or 60 CEUs.
Yes, they always have to learn, because that's the problem, not his ego.
Exactly. So they had to go do some CEUs. They were not allowed to have, which seems like such a punishment. Can't have residents. Can't have students anymore.
People. Yeah.
Oh, what a bummer. And then they're still practicing. Basically, they had to keep doing that. They have to report back. They have to like show a few of their notes. They have to obey all federal, state, and local laws. That was specified.
Unlike the rest of us.
Yes. We're just doing whatever.
Exactly. And Dr. Naeem also paid $1 million in settlement to her husband, Kira's husband, in the wrongful death lawsuit. So that was like a previous one. And now, his insurance already paid it out. So that's kind of like Kira's husband already fought that. This is against the hospital, saying that you should have done something differently, and that this is more of a, basically like this was like a race-based, like you didn't listen to her because she was Black, and now we're here. Look at how many things you ignored. A panel of people on the internet could have solved this quicker than you, my friend. And only one of us works in labor and delivery.
In like 10 minutes, we could solve this crime. Could have been done.
That's the point, though. You don't even have to work in labor and delivery to look at it and be like, what the heck was going on here?
What's going on?
At 5:30, I'd be like losing my mind.
Now they're just suing the hospital. They're not suing like the nurse and everyone. You know how sometimes lawsuits are like with people plus the hospital?
So they listed in the case, I think there were a lot of people that they listed in it they did, let me see.
I think there were a lot of
I think they listed a bunch of people. Yes.
Okay.
A ton of does. So people weren't necessarily listed individually, but it was against, I think, like almost everyone that interacted with them.
They interacted with
in
her.
that time period
Every
who did not sound an alarm. Yeah. Who did not sound an alarm bell. But it's all wrapped up into this case against the hospital. It is so sad. I mean,
sometimes you can't predict these things. Someone comes in bleeding and you kind of do what you can do with the information that you have. But it seems like you had all the information, way more than most situations, and you could have stepped in at any point in time, and you just didn't. And I don't really know what their rationale is going to be as to why they didn't feel a rapid intervention was necessary in this case.
And Boho has been commenting in the chat a lot, and I think she said at one point, like, this is literally what you do in postpartum. Like,
exactly,
this is what you look for. You know what I mean? Like, this is what
number one thing
you are there.
Oh, is it?
Yeah, to look for is bleeding.
Yeah.
I was going to say earlier that it just to keep us honest, that this is kind of armchair quarterbacking, and we have we have hindsight bias, and we don't have a physician. We have a great OB nurse on panel, but we don't have an OB physician because medical thinking is different than nursing thinking. So there may be things like you said that we don't know, but I mean, like if you're waiting because there's some kind of risk to go to surgery, she's becoming a worse anesthesia risk as her blood pressure drops and her heart rate goes up. So the longer they wait, the worse it gets. But yeah, there's certainly lots of questions. And like you said, and I always wonder, I have to say, about research when it's like, there's a racial difference, Black women, white women, or Black folks and white folks. I'm like, because poverty is more, there are more, how do I want to say this? Poverty, there's often a correlation between race and poverty. Do they control for that? Because I wonder if white women also don't experience discrimination and poor health outcomes and all this. And I'm glad you said that they did control for these other things, looking at mortality. So there must be something. There are good questions to be asked, and I think we've asked some of the good ones here.
Yeah. Healthcare has done a really good job of trying to find any reason other than racism I found, because a lot of studies will look at it and they're like, it's gotta be
something
income
else.
level.
It can't be that, guys.
It's gotta be the income level. And then every time, like, why aren't nurses getting promoted as much? And then it comes back and it's like, no, the only difference was race. They're like, no. Okay, it has to be this. And then they do another study and it shows it again and again and again. And then it's funny because people will come into my comments and like, it's not that. I'm like, oh, friend.
Well, it is hard to swallow, especially for people that don't see themselves as that either have recognized their own racism and trying to work on it, or that, I mean, my parents specifically brought me up without racist influence. That was something my mom and dad discussed before they had me. So, not that I'm never racist, but I mean, I wasn't brought up with that. It's hard for people who pride themselves on being fair-minded then to hear that our profession has problems with racism. And like I said, especially in the Midwest where we don't speak it, we might say things like, she was a very good patient, she was well behaved, may not even think of that as being racist. And so it's really hard to accept that kind of research sometimes. I don't know if you have any advice. I mean, other than we just have to have open minds and,
I think going into it and just realizing, like really examining every single bias that you have and having some really difficult conversations with yourself of being like, oh, wow, I did expect this discussion to be different than it actually ended up being. And like, why am I surprised? You know what I mean? Like, why am I, like having all of that and just then doing whatever you can to try to push it in the opposite direction. You know what I mean? And being like, the biggest thing I found that has been, I mean, who knows if it's actually moved the dial, is just calling people out on their crap immediately, like, which is uncomfortable and does get slightly more comfortable the more you do it. But like, when you hear someone being like, oh, she was so nice, kind of just like little, like, did you not expect her to be? Right. And it kind of, puts it back to the other person to be like, oh, like, how do I explain it in the South?
They always find a way to beat around the bush with it.
Yeah.
They do.
Exactly.
They have ways.
Yeah.
Tactical.
Yeah.
Yes.
But in North Carolina,
but childbirth was never anything magical. Even with my first kid, I knew it was going to be like, this is going to be a battle for you just to be listened to. Not that I was expecting to die, but that was always like, this might not go well. I see all these people on Instagram with their bellies. And every time I went to the doctor, I was like, okay, make sure, everything's okay. Make sure that you say this, even if you don't say it directly, kind of quasi mention it, because childbirth is a scary process and you don't know what you don't know. And even when you do know enough to be dangerous like me, you don't know the OB stuff and you don't know how much is too much blood, but how much is normal. And you're putting a lot of faith in a very small amount of people in a very, very critical time in your life. And in this case, not that she didn't even trust the right people, they just did not advocate for her and they didn't do what was in her best interest. And that's sad because all you have is the people that are around you. You can't request another doctor. I mean, you can, but they're always in the same group. And they work for each other and they don't want to step on each other's toes. And then you're in a weird political thing. And hospitals are very political. I'm learning the older I get.
Oh, yes.
That's why we have nurses. We have people on another team to advocate for patients. I mean, if we're doing it right. If we're doing it right.
That's why I'm at home on the internet and not out there.
And something struck me too about this, that the husband was continuing to make a stink throughout this instead of just saying, well, the doctors, they know best. Right. To make a stink. And that speaks a lot to patient empowerment and family empowerment. And last time I think we talked about a video I made, like how to complain in the hospital, because it's a weird place. People who patients don't know. And we touched a little bit about where the nurse should complain, but the patients too. If you're not getting the results you want, you call the nurse supervisor and you say, hey, either explain to me what they're doing or tell them to do what I want them to do, or, and there are, there's a hierarchy at nursing side and on the medical side that you can go to that I think a lot of patients just aren't aware of.
And sometimes it's not even about the nurse's care. I mean, that nurse could not have taken that patient to surgery. That's not his or her call. All they can do is communicate and document and do the orders. That's not her call. But it seems like, she was notifying people. She or he was communicating what needed to be done. But yeah, that needed to be escalated. But I don't think that might not be 100% on him or her as to the outcome of what happened. There were so many moving parts there. But yeah, a lot of people dropped the ball on that one.
Yeah.
Yeah. Yeah. And something else I found interesting was a lot of these cases never get brought, and they were talking about how this one ended up getting the actual attention because a lot of people will not take these cases because they're like, I can't really prove that. Like, how do you want me to even prove that? Her mom is Judge Hatchett on, apparently that's someone on TV. So she has a huge,
Oh, really?
like, she's famous, and that is how they got this to even get brought, was because she pulled that and said like, hey, or her mother-in-law, thank you, whoever said that. I
Oh,
know
gotcha.
nothing about this person, obviously, but like, she's huge, and so that's how this even got on the forefront, because most of the time they won't even touch it. Because
Yeah, that's
like,
what I was
well,
told with
I
my
know if you prove
situation,
that.
that the goal, if I'm going to defend you, I have to make sure that I can definitely get $300K out of this. And since your kid's not permanently disfigured, I'm not going to get that money, so it's not worth it. So they have to make sure that they get their money to make it feasible. And that's why you never hear about things like this.
Yeah. Yeah.
Oh, that's so sad.
It is very, very sad.
Oh,
Let me get this super chat real quick. And then I thought we could all wrap up with just a way to tell people to maybe add like something tangible that people can use to advocate for themselves. So that we don't end on
a bummer.
I mean, it's such a bummer. There's no getting, I don't want to make it like, say like, oh, let's make it not a bummer, but just like something actionable that you can do with this.
That will keep, for sure. Because things like this will continue to happen. So any tips are very helpful. Yeah.
Exactly. Caleb Forth, thank you so much for the super chat. FYI, MD board actions are 1/10 the punitive cost of nursing board actions. So is that like,
oh wow.
That doesn't surprise me.
No, not at all.
So basically you get a slap on the wrist, but that's because physicians make the hospital's money.
They make the hospital's money, and then they're like, how am I going to live? You take my license away, and I work so hard and I have student loans. It's like, yeah, man, you and everybody else.
When I was reading what the doctor in this case got, I was just like enraged all over again about Redonda Fott.
Yeah.
Isn't that crazy?
All of them.
Wow.
All of them.
This is not level playing field at all. Like,
right, exactly. Okay.
Yep. All of them. Like a joke. Just a joke.
And I will say, just real quick while I'm sorry.
No, go for it.
Another thing about that, Dr. Naeem, I was just watching a really old interview with Charles, the husband in this case. I think this interview was from 2017 or something. And he was talking about how after she died, it was 2 residents and a different physician, I'm guessing maybe Churchill, who came to tell him that she had died. And then like Naeem he wasn't the one to go and tell him. And then hours later, like the next day, because he's still like in postpartum with the baby, because, he still has the baby. Churchill came and asked him, like, is there anything that we can do for you? And he said that Dr. Naeem had never come to tell him. He didn't come to tell him, and he didn't come to see him at all after it happened. And so Naeem ended up going to talk to him. And Charles said that he asked him, what would you have done differently if this was your wife? And Naeem's response was, do you mean as a husband or as a doctor? And Charles said then that he was just like so enraged, he told him to get out. Like he told Dr. Naeem to get out.
He had a moment there to kind of,
like,
to be empathetic. Wow. Right. What a great dude.
Yeah.
Jesus. Oh my gosh. I can't imagine that he didn't go and tell them.
Yeah.
You know what I mean? Like, I feel like if
you owe them
anything,
that much.
If it's your patient that dies, it's going to come out of your
were
mouth.
so
I've had those
confident
conversations before. It's gonna hurt you. You feel guilty, and I totally understand that this is gonna be uncomfortable for you, but this patient's dead. Get over that. This isn't even about you.
Right. But it just shows that the whole thing leading up to her death was his ego playing a part in it.
Exactly.
And he obviously
And
feels
if you
bad.
get to tell
Like,
patients,
Right.
if you get to tell patients every day, congratulations, you have a bouncing new baby boy or baby girl,
Yeah.
yay, then you have to also have this discussion once in a blue moon.
Right.
Right.
Sure.
Right.
Exactly.
Only fair.
what a
I'm sorry, I didn't mean to
Good piece
bring
of
it in
work.
a little bit further before.
Oh
we
no,
ended.
I really appreciate it. That's like why it was so helpful to have all of you on here, which I super appreciate. By the way, Doc McFuzzball said amazing panel, and I so agree. This was like the most helpful conversation, I think, and I am so immensely grateful that all of you gave your time for it. Do please, if you watched this, go down and check out all of their social media, all of their anything they would like to promote, because this is the conversations that they're having on their channels too. And you should follow them. I basically just spammed all of my favorite people. And was like, if you ever want to come on here and talk to me.
I was like, Nurse
so
Liz, oh my God, she knows my email.
I know. I was like,
Just fangirl,
Nurse Nicole
just
was my
for a minute.
celebrity.
Just for a
She
little
was
bit.
my celebrity outreach. I'm like, I'm going to throw her on here. I'm going to throw her onto this email group. And
I'm not doing anything.
I
These
felt very
kids sleeping
famous.
all on me. Let's talk.
So yes, thank you so much for that super chat. And thank you everyone who did come and be here. I very much appreciate you. Do you guys have anything that you would say, like to tell people like what they could say if they're ever in a situation like this, or their family members where you feel like you're not being heard and you need it to be communicated? Anything that they could say differently to help them feel like they are like being more heard?
I think my best tidbit that I could give would be go with your gut. If you don't have the right vibes from a doctor, a nurse, be comfortable with asking for somebody else in a respectful manner, because sometimes it could be that conflict of interest or just personalities that don't mix, and it blocks the care that you should be receiving. And if you have that inner thought that's saying something's not right, most likely something's not right. And somebody has to stand up for you, whether it's your spouse, your mom, your dad, whoever it is, but somebody has to be willing to say, we need somebody else to care for my loved one.
I love that. And I've had that. That's my number one thing that I will tell people is to just, if you feel like, and the vibe is off and it's probably spiraled, right? Because someone is scared. I have had this with my own loved ones where I feel like they thought I was super aggressive about a situation, and kind of just recentering it and be like, okay, I feel like we have really gone off in a different direction. Like, I just want to bring this back to our situation right now. Like, we have like both had, something going on. You don't like me, I don't like you, but like, let's just bring it back really quick and look at like, I am concerned that you are not seeing, like, I am worried about this particular thing.
Correct.
Like, please tell me why you are not, or why you are, and like what our steps are going forward. Like, what is the next thing we're going to do if this specific thing doesn't work? And that's usually brought people out of, and people have done this with me, where it brings you out of like, okay, we're fighting, like, let's refocus for a moment and just like do this. And then, even if you have to tell people like, then we never have to talk to each other again. Okay. Like, let's just get through
I've had some attendings that are like, this nurse is dramatic. I'm like, yeah, but I don't really care about what you and her dynamic is. She's calling us over there. We can deal with that later. The personalities, he doesn't listen to me, I don't like her. This is about a patient. Let's just go see. It's not, there's all this underlining like personal stuff that the patients have to sadly deal with. Like, oh, this attending doesn't like this surgeon and he's on, so we're going to wait 4 hours and all this other stuff. Or the nurses to patient ratios are really high, and patients don't really care about that stuff. They shouldn't have to care about that stuff.
Yeah.
Just advocate and ask them what their kind of escalation process is. If the house supervisor isn't there, who do you go to next? My husband had to do that with our kid who had autism in the hospital. Okay, I don't know how PACU works. Since I don't like talking to this person and they're really not listening, who's above him? And I just keep asking politely, then who's above this person?
Yep. That's
and
a really
you just have
tactic.
to keep going.
Yeah.
I don't care if you don't like me, I'm nagging, I'm annoying, that's fine. But those are the people that get things done. The people that don't say anything, oh, sorry, my kids, nothing. It doesn't matter if they like you or the patient, or they're like, oh, this family's so dramatic. That's that. They're just advocating for their family member. Let them be as dramatic and as loud as they need to be, because that's how you
Yep.
get things moving.
Absolutely.
I would say it's really important to bring someone with you, because
Yeah.
in the moment, sometimes it's hard to think on your feet. And I mean, I had a video on a complaint I made at the hospital as an outpatient. And in the moment, I was like, all right, thank you. And then I had to think, wait, she was being a bitch. I'm going back. I'm lodging a complaint. To have someone, have someone with you that can kind of see things. Plus, if you're in pain or if you're nauseated or you're worried about your own health, having a third person, I'd say bring someone with you. And I want to normalize for everybody out there that it's okay. This happens. You're like, I don't want to be the only one to ask questions or raise a complaint. People complain all the time. People ask questions
every day.
It's completely normal. So please, when you're at the doctor, when you're at the hospital, ask questions, ask more questions, ask to talk to people, say, I'm not quite satisfied with this. Can you at least tell me why you can't give me what I want?
Right.
It's normal. You can do it too. And one other thing I got to say, somebody in the chat said, well, can a family call a rapid response? I'm like, oh no.
Oh yeah, I saw that.
Yeah. Usually, most hospitals have a number that they can't call. It's on a poster. I don't know.
At our hospital, family members can. And we have signs on the wall that says that they can call a rapid response.
Yes.
Yeah.
Really?
Ours, they can't call a rapid, but
we have
it's
a
like
button on the wall.
Yeah.
Oh, see, that's hardcore. Ours, they could just call a different number and it would run it through one person, I think, before it activated it. And you did not want to be on the receiving end of that when your patient diverted around you and it was a serious problem.
Correct. For sure.
Yeah. There is a big red button on the wall behind the bed. And
I was going to say,
maybe you think you're not supposed to touch that. And I kind of think you shouldn't, but
yeah,
in an emergency, if you really are that, I'm going to piss somebody off. Like, oh man,
Oh,
Scott
no.
told everybody how to call a code. Now I got patients calling codes and it's all Scott's fault.
Oh, calling a code for water. I just needed some water. I'm like, wow, dude, are you serious? Like, okay.
I had so
You got
funny
the
story
whole
about
code
patients
team.
calling rapid responses. I said it's a button on the wall. I'm sitting. It's like a really quiet, as we would say, a quiet day, and I'm just like, I'm just kind of chilling. I've done my assessments like mid-morning, and on the overhead, I hear like rapid response, and I always only like halfway listen to them because they are never for my floor, and and it's like rapid response, 3rd floor, room 303, and I'm like, that's me. And I like run down the hall and I open the door and the mom's just like holding her baby, like looking at this thing on the wall. And she's like, oh, did I touch something wrong? I was like, I'm glad that you're fine. I'm glad that you're okay.
Good though. She's good.
And I'm like having to like shoo everybody, like because the whole hospital comes whenever a rapid response gets called.
Oh yeah.
That never happens. So
Yep. Ours, they had to change what the actual button said because parents kept hitting it and you'd be like, oh my gosh, what's wrong? And you'd come in there like, oh, I just needed a blanket quickly. And you're like, okay, no.
Faster than I wasn't kidding.
They're like, I thought this was like the faster call button. I was like, oh no. And kids would learn, like little toddlers, especially if their parents weren't there, they knew the buttons on the wall made the people come. So you would have kids like reaching out of their crib or throwing stuff at the.
Oh, they're smart. They're smart ones.
Oh, they're smart.
Need the plastic cover. Need the plastic cover.
Kids would pull out if they had a trach, they would pull their trach, or they would take their eye like to make themselves stop breathing because they
and it beeps and then you come.
If they had a pacemaker, batteries in the iPad case, they'd put on their stomach where their pacemaker is and just watch their heart rate go like boom. Boom. And then you come by and they're like, ha, 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 and you're like,
they're playing, they're on the line, they're playing games.
Exactly. But then you look like the jerk because you're like playing a gamble with this 4-year-old and everyone else, the people are walking by, they're like, oh my gosh, look at that heart rate. And you're like, yeah, let's see how low they go. And people are like, what is wrong with you?
Where they're going to learn.
Yeah.
That's why I don't work with kids.
You're like, this is called discipline. Yeah, exactly. This is called discipline. We're learning the
healthy boundaries.
Oh my gosh.
One piece of advice for people having babies. If you are able to and have the means, a doula is a great thing to have.
Okay, can you explain to me what that is? I have no idea. I see the word and I think I know what a doula is, but I don't know. Could you educate me on what?
So a doula is a non-medical support person that is trained specifically to support you during pregnancy, labor, delivery, and postpartum. So they will provide non-medical advice. They will like physically support you during the labor, give you massages, help you with different positions that would be good for a labor, help with pain control, especially if you're trying to go naturally. And then some doulas or some specialize in the postpartum period, they will come to your home and they will help you with anything that you need at home, whether that's like doing the laundry or breastfeeding or, you know, feeding your other kids. I mean, it's kind of like, it's a really great service, but they are there to be a voice for you. They are your advocate on a that is not attached to the hospital, which can sometimes be a very valuable thing, because as nurses, we are advocates, but you know, we kind of like have this like half, you know, this line that we have to kind of walk. But they are not part, usually. I guess there are some places that do have them, but usually they are not associated with the facility. And so they can really kind of like speak up and be more firm, especially if the patient doesn't have that voice, you know, really to talk for themselves.
And they won't talk you out of an epidural. I saw this question in there. If you want one, they will help you advocate for that. If you don't want one, they might be there to be like, do you really want, like, they're your, like, you kind of have your pregame huddle, and they're going to try to make it, they're more comfortable in that environment. You know what I mean? Like,
they're there to make sure that your preferences are taken into consideration and met as much as possible.
And respected and making sure that things are going okay. Oh, wow.
Exactly. And they're not freaked out because they do this, like, they've seen this. It's kind of like when you bring your nurse friend into the hospital who's familiar with that unit.
Oh,
you know, and they like, because your partner usually at that point is just like more useless than you. No offense, Scott, but.
But the thing with doulas is that
when my mom goes to the ER, I get FaceTimed in when the doctor comes to give instructions. This is my son. He's a nurse. He's just going to listen. Go ahead.
And you're just like,
absolutely.
You're like, can you start over? I'm like, Dad, just be quiet. Just be quiet.
Well, I'm across the country, so it works.
Oh, nice.
Perfect. And Karen, I agree. That's kind of why I want to start having these conversations with all sorts of I think these get the conversation started, because we do need to have a lot more conversations, not only like about, racism in healthcare, but also like there's so many other things we have to talk about in healthcare also. Like, there's just a mess. So I've recruited some people to talk with me about it on the internet to try to fix these things. So I think we're going to wrap up. I told my husband we'd be done at 5, and now it's 6. So it's totally fine. This was like
here, he's looking at me like, you're not done yet?
Yeah,
you said you're gonna be
exactly. But honestly, this was like the best conversation. I am wildly thankful for all of you for joining me on it. Feel free to stop by whenever. I give you about 2 hours notice, as you found out today. So I'm really good at planning ahead. I'm very in charge of my life.
Super organized.
All as well. But please go check these people out in the description. Let me know if you guys liked this type of format. I thought it was really fun. And if you guys ever want to do anything on any of your channels, whatever, I will be happy to jump on something. 2 hours notice as well.
I'll hold you there.
Please don't. All right. Thanks everybody for watching. I hope you learned something and we can continue to talk about this type of stuff. Remember, you are not alone. You are more than enough. And you, my friends, can do hard things. And we'll see you next time. Bye.
Bye.